Welcome to Dr. Tristan Anaesthesia Tutorials. This podcast is an educational resource for medical students, anesthesia trainees, and qualified anaesthetists worldwide, offering evidence-based clinical anesthesia teaching and exam preparation support. New episodes drop every Monday and Friday, with bonus episodes every Wednesday. Subscribe on Patreon for exclusive content at patreon.com/Dr. Tristan Anaesthesia Tutorials, and follow us on YouTube, Spotify, Apple Podcasts, X, Instagram, and Facebook. Just a disclaimer, this podcast provides general educational content and is not a substitute for professional medical advice, diagnosis, or treatment. Always consult qualified healthcare professionals and primary academic sources for specific guidelines and guidance. This content is separate from Dr. Tristan Leonard's practice as a specialist anaesthetist and is not affiliated with the Colleges of Medicine of South Africa, the College of Anaesthetists, or any university except for the purposes of CPD registration, where applicable. Dr. Leonard is not currently involved with CMSA examinations, and listeners are advised not to rely solely on this podcast for medical or exam preparation. Thanks, guys. Hi, guys. Welcome back to Dr. Tristan Anaesthesia Tutorials. I am Dr. Tristan. It's good to be with you again. And today we are starting Neonate Week. So we are going to be discussing, to start off with, comprehensive neonatal anesthesia. We're going to specifically talk about prematurity and managing perioperative risks. So this is now episode 7. I'm very excited. And this is part of our pediatric anesthesia section that we started off with. But today and tomorrow, Thursday and Friday, we're going to be focusing on anesthesia in the premature neonates. And I really hope you guys enjoy this. And I'm also going to be presenting some Dr. Tristan Explains to the public sections, giving some information on neonatal anesthesia and prematurity, etc. So what are we going to go through today, guys? Well, we're going to start off with just an introduction to neonatal anesthesia. We're going to talk about understanding prematurity, the risk factors of prematurity. We're going to talk about morbidity and mortality in premature neonates. And we are going to talk about neonatal physiology, neurological and renal issues. We're going to talk about anatomical considerations, especially in the airway. We're going to talk about the pharmacology of neonates, and we are going to then go over what I really think is such a cool framework that was taught to me by colleagues of mine when I was a junior, the HARSH framework, whereby the H stands for housekeeping, which is essentially getting your house in order and ready for a premature neonate. The A is managing apnea risks. The R is retinopathy of prematurity. And we've got a brilliant separate guest lecture coming tomorrow, guys. I'm very excited by a good friend and a surgeon that I work with, Dr. Claire Cullen. And she is going to, she's giving us a wonderful talk on all that we need to know about retinopathy of prematurity. The S in HARSH then stands for shunts, and the H is hemorrhage and the management of blood loss. Then we're going to just go through a premature neonate case study, and then we're going to summarize and talk about some future directions, etc. So that's what we're going to go through today, guys. And I really hope that you will find it useful and that it will be a good start to our neonatal anesthesia week. So let's get going, guys. Number 1, an introduction to neonatal anesthesia. Well, essentially, the neonates and the premature neonates is a subset of pediatric anesthesia. But I really think that if we want to be really accurate and safe and all of that, it should be considered its sort of own version of anesthesia, or a subset of pediatric anesthesia. Prematurity is a huge issue globally. And it's a bit of a double-edged sword, and it's something that we will talk about more when we have a little bit of an ethics discussion later on in the week. With our medical facilities, with our ICUs, our surgeons, our anaesthetists, depending on the country, 400 grammars, 500 grammars. The smallest child that I've ever anaesthetized that survived was 678 grams. So we also get to the point, if just because we can save them, should we? Because the comorbidities and the long-term complications that come from extreme prematurity are really something that we need to take into account. But there is long-term medical care that these children will need. We're going to cover general information on prematurity and cover just some core physiology issues, pharmacology, anatomical issues. And then, as I said, we're going to talk about the HARSH framework. We're then going to have a case discussion, and then we're going to end off talking about mitigating risks in neonatal anesthesia. So let's just understand prematurity for a bit, guys. And the first thing that we need to do is just define things. I love a good definition. So prematurity is defined as birth before 37 weeks of completed gestation. And you can then look at the severity of the prematurity and get different definitions. So extremely preterm is babies that are born before 28 weeks of gestation. Very preterm is between 28 and 31 weeks. Moderate preterm is 32 to 33 weeks. And then late preterm is 34 to 36 weeks. And obviously you guys can understand as we go from left to right, from extremely premature to very premature to late premature, the risks, the complications, the length of hospital stay, the number of surgical admissions, and the long-term morbidity as well as the mortality risks are totally different in those instances. If we look at the sort of epidemiology and what are risk factors for prematurity, we need to understand that roughly 10%, so 1 in 10 pregnancies will end with a premature birth. Maternal and socio-economic factors are things such as maternal infections, high rates of hypertension, TB, HIV, etc. And then socio-economic statuses, poor access to healthcare, poor access to maternal care, poor access to neonatal screening, to prenatal vitamins, etc. The complications of prematurity can be really severe, and they can range from respiratory distress syndrome, bronchopulmonary dysplasia, necrotizing enterocolitis, interventricular hemorrhages, and retinopathy of prematurity. Remember, guys, that in addition to that, there are the increased risks of all of the nosocomial issues that come with prolonged hospital stays. So this is things such as sepsis, hypothermia, hypoglycemia, and they have a high risk of long-term neurodevelopmental delay. And then from an anesthetic perspective, this can be incredibly challenging. These children are tiny, vascular access is difficult, tubing them is difficult, ventilating them is difficult, blood loss is difficult, all of those things that we're going to talk about when we talk about the HARSH acronym. So I love doing neonates. People call me crazy, but I find it incredibly rewarding. But it can really go pear-shaped quite quickly, and these kids are really sick. So remember that globally, if a child is born at 24 weeks, there is a roughly 50-50% chance of survival, up to about 70% in very first world countries such as United States, Singapore, etc. If a child is born at 32 weeks gestation, 95% of them should survive. Long-term morbidity and mortality is up to half of all survivors will have some form of long-term morbidity or mortality. That may be something as severe cerebral palsy, where they are totally dependent and they are totally disabled, all the way to visual issues, long-term problems with visual loss from retinopathies or congenital cataracts, and maybe some intellectual disability and delay. Premature infants have a 2 to 4 times higher perioperative risk of morbidity and mortality compared to those born at term. So it's not just a small term baby, it's a whole challenging entity on its own. And multidisciplinary care is required because these children tend to have a minimum of 2 long-term morbidity complications that will need multidisciplinary team management. So we can get them through the neonatal period. I then often won't see them afterwards, but just don't forget, guys, that they a lot of them, up to half of them, will have long-term morbidity and complications. So how do we mitigate risk? Well, obviously, those of you that have tuned into the channel for any length of time will know that I'm obsessed with multidisciplinary teamwork. So we need early neonatal consultation, ideally in the pre-birth period. But if the baby is being delivered emergently, we need to contact the neonatologist early. And that neonatologist then needs to contact cardiology, renal, etc., depending on what abnormalities are there. They might need to contact the ped surgeon and then me, the pediatric anaesthetist. We need to risk stratify and look at kids based on their birth weight and their prematurity. So there's extremely low birth weight, there's very low birth weight, and there's low birth weight. And by looking at their prematurity, so their weeks of gestation, and combining that with their birth weight and comorbidities or organ issues at birth, allows us to risk stratify and allows us to give better odds of survival, of complication rates, of long-term morbidity and mortality, which allows everyone in the team, and especially the parents, a good opportunity to make sure that they make informed decisions. Then obviously, if they're going to come to theatre, we really want preoperative optimization. And these are things such as the use of steroids in the prenatal period to get surfactant production, the use of artificial surfactants for respiratory distress syndrome, as well as things like maintaining a normal glucose, broad spectrum antibiotics to prevent infection, and maintaining a normal circulatory volume and a normal hemoglobin. And then there must be collaboration between the neonatologist, the ped surgeon, the anaesthetist, the intensivist, and the nursing team, so that we ensure we're all on the same page when it comes to managing these kids. So let's look at some specific neonatal issues that we want to focus on and that we must be aware of in this period. Number one is respiratory complications. So remember that immature lungs do not produce enough surfactant. Surfactant is what allows the alveoli to remain open. From a physiological point of view, we'll discuss that in a full physiology lecture. But just remember, if you look at Laplace's law and the law of surface tension, okay, a bubble will want to collapse in on itself due to the surface tension forces. Surfactant breaks the surface tension up, allowing these to be open. So respiratory distress syndrome in a premature infant, especially below 28 weeks of gestation, is pretty much guaranteed. So the lack of surfactant, the need for artificial surfactant, complicates the ventilation. Remember, oxygen is toxic to them. Too much oxygen can cause bronchopulmonary dysplasia. We also need to keep in mind that premature neonates, though, have got increased oxygen requirements, roughly 6 to 8 moles per kilo per minute of oxygen versus 3 to 4 moles in adults and older children. So they desaturate incredibly rapidly. And if you think that an infant or a child gets a Brady when they get hypoxic, you've seen nothing in a premature neonate. Their heart rates are so exquisitely sensitive to temperature, to acidosis, to oxygen saturation, etc. It can be really spectacular and quite scary. And then remember that they've got unique respiratory parameters. They don't really have a great hypoxic respiratory drive. They don't really have a great hypercarbic respiratory drive. And everything we do in anesthesia causes apneas. The meds, the volatiles, getting cold, bleeding, etc. So we've got to be aware of the respiratory considerations in these kids. So moving on, the next thing that we need to take into consideration is the cardiovascular and thermoregulation issues in premature neonates. So from a cardiovascular point of view, remember that all of the changes in a term neonate, or all of the issues, are manifested 1,000-fold, okay? So they've got a very high heart rate. Minimum, I want a neonate to not sit below 120. To be very honest, I prefer a premature neonate to sit with a heart rate of 140, 150. They are exquisitely rate dependent. They've got a tiny little left ventricle that can accommodate 1 or 2 mils of blood. Their stroke volume is literally 1 or 2 mils per kilogram. So if they weigh a kilogram, their stroke volume is 1 mil. If they weigh 800 grams, their stroke volume is theoretically 0.8 milliliters. It's tiny, guys. So they are so exquisitely rate dependent, they cannot increase their stroke volume. Okay. So under stress, they get bradycardic. If they have pain, they get bradycardic. Hypoxia, they get bradycardic. If they are hypoglycemic, if they are cold, if they are acidotic, if they bleed, if they are hypovolemic, they will get a bradycardia rapidly. Remember then, guys, that you have to be aware of the impact of physiological stresses on the risk of reverting to the fetal circulation. So remember when we went through the physiology, we spoke about the fact that in utero, you have a ductus arteriosus that is open so that blood can go directly from the pulmonary artery to the aorta. And you have a foramen ovale, so blood shunts between the left atrium and right atrium. Once a neonate is born, especially a premature neonate, they undergo the same physiological and cardiovascular changes as anyone. The oxygen tension, the breathing in, the sudden drop in pulmonary vascular resistance, and the sudden increase in systemic vascular resistance because you've lost this low resistance bed placenta causes them to have the PDA start, the ductus start to close, and the PFO, the foramen ovale, start to close. However, premature infants, especially the more premature they are, below 32 weeks, then 30, then 28 weeks, they don't have a lot of muscle to close that ductus. So they often have a patent ductus arteriosus, and their foramen ovale takes a lot longer to close. So if you have hypoxia, hypovolemia, acidosis, SNS, stress response, and you get an increase in pulmonary vascular resistance, you can very rapidly revert to the fetal circulation, whereby blood will now shunt from the pulmonary artery. Deoxygenated blood will shunt into the aorta. That will cause more hypoxia, more acidosis, and it can be a very frightening slippery slope. Thermoregulation is a huge issue in these children. They do not have non-shivering thermogenesis. They've got very limited brown fat stores. Their heads are huge, and their core temperature can drop at 1 degree an hour, 1 degree every half an hour if you don't pay careful attention. We have to manage their temperature, and remember it's 2 ways. They're tiny, so they get cold quickly, but they get bloody hot very quickly as well. So you can overheat them as well. So don't just focus on hypothermia. Be cognizant of overheating these children. We need to then just focus on a little bit of neurological and renal issues. So their brainstem is immature, and they've got an incredibly high risk of apnea, okay? And the apnea risk is something we will talk about in more detail. But they essentially have got a much lower respiratory drive from the brainstem. They also have very fragile cerebral vessels that are at a very high risk of interventricular hemorrhage. This can often occur when there are wide swings in blood pressure, so from hypertensive to hypotensive, if there's extreme pain, if they, God forbid, are trying to do awake intubations, etc. They have immature renal and hepatic function as well, so their ability to both metabolize, conjugate, and excrete drugs are limited. Their ability to have protein binding with albumin as well as alpha-1 acid glycoprotein is limited. So neonates will have an increased free fraction of drugs. So what does that mean for anaesthetists? Well, it means that drugs have got prolonged half-lives. It means that these children are much, much more susceptible to side effects and complications of drugs, and that we need to try and give them short-acting medicines as much as possible and avoid drugs that are heavily reliant on hepatic and renal metabolism and excretion. We now need to focus on something really quite critically important for a few minutes, guys, and that is the airway. So the airway of a premature infant or neonate is, by definition, in my opinion, a difficult airway until proven otherwise. And why is that the case? Well, there are unique structural challenges, okay? There's just size issues. It's a tiny mouth. It's a tiny little epiglottis. It's a tiny little vocal cords. It's a tiny little opening into the airway. And getting to see that with a laryngoscope blade and a tube, it can obstruct your view of everything, okay? So they've got a large occiput, short necks, and relatively large tongues in this tiny little premature baby who weighs 900 grams mouth. It can be quite frustrating. The large occiput causes them to flex forward and they obstruct very rapidly. And what one needs to do is one needs to bolster something under the shoulders so that the tragus, okay, over here, is in line with the sternum as they are lying flat. They've got very narrow nasal passages. And remember that premature infants and all infants are obligate nasal breathers. They are also potentially at risk of a condition called choanal atresia, whereby they actually don't get the holes, the choani, in the nose. And that is a surgical and dire emergency because these children cannot breathe properly and they cannot breathe when they feed. But even with normal noses, they've got tiny little noses, any secretions, mucus, blood, etc. will block those airway passages very quickly. We also need to consider that any inflammation in the airway from repeated instrumentation and attempts at intubation will cause rapid increase in airway resistance, and these neonates do not have the capacity to deal with that. The larynx is much more anterior and much higher compared to adults, so visualization is difficult. In terms of preferred equipment, the standard teaching, which I've referenced in the talk here, is to use a size 0 or a size 00, a size 0 or 00 straight blade. Thank you so much for watching and listening to Dr. Tristan Anaesthesia Tutorials. Please remember to like, subscribe, and share to support the podcast. For exclusive content and absolutely everything else that you could need, join us on Patreon at patreon.com/Dr. Tristan Anaesthesia Tutorials. And remember, follow us on YouTube, Spotify, Apple Podcasts, X, Instagram, and Facebook. And then just remember, Dr. Tristan Anaesthesia Tutorials is an educational resource for the global medical and anesthetic communities. It's not a substitute for professional medical advice, diagnosis, or treatment. While every effort is made to ensure accuracy and alignment with current medical advice, this podcast should never replace peer-reviewed journals or textbooks. It is independent of Dr. Tristan Leonard's anesthetic practice and is unaffiliated with the Colleges of Medicine of South Africa, the Colleges of Anaesthetists, or any university except for CPD accreditation where applicable. Dr. Leonard is not involved in any CMSA examinations. All content, including audio, video, and notes, is the exclusive copyright of Dr. Tristan Leonard. Unauthorized reproduction or distribution is strictly prohibited. For medical guidance or exam preparation, please consult qualified professionals and primary medical sources. Thank you again.